Okay, good afternoon, everybody. Today, my topic is about platelet function and thrombosis, and I like to share my new insights with you. So there are several applications for platelet function tests. Um, Today, I will only go into three of them, but of course there are a lot more. But the three main subjects are bleeding disorders, monitoring platelet inhibitors, and estimating the thrombosis risk. So I will briefly go into the bleeding disorder and the monitoring of the platelet inhibitors, and then I will go into the most difficult part, is the role of platelet function test to estimate thrombosis risk. So platelet-related bleeding disorders are mainly mucocutaneous bleedings. So that means in your mucus or in your skin. Well-known examples of that are oral cavity bleeding, gastrointestinal bleeding, prolonged bleeding after you cut yourself, heavy bruising, prolonged bleeding after tooth extraction, menorrhagia, and nose bleeding. Well, to define a bleeding disorder in patients who have bleeding symptoms, the first step is always to exclude the most common coagulation defects. So see if the APTT and PT are excluded, are prolonged. Well, if you show that those are not prolonged, then the next step is to look for platelet disorders. And the first step in screening for platelet disorders is very simple. You just do a cell count and see if the platelet numbers are decreased. So check if there's thrombocytopenia. Another general test is to look at the morphology, so simple blood smear and look at the morphology of the platelets in relation to the other blood cells. And another screening test is a global hemostasis measurements with the PFA 100, for example. There are also alternatives. And in the past, the labs used the bleeding time for this to see if there is a primary hemostasis-related bleeding defect. Now, always in combination with those very global tests, the labs can do a precise platelet function test to see if there is a specific pathway deficiency. And the most commonly tested, which is already operating for more than 60 years in the routine clinical labs, is light transmission aggregometry, which is recently improved by including also the luminescence, so LUMI aggregometry. Also, more recently, it has been shown that flow cytometry might give additional information in bleeding, in the definition of bleeding disorders, so additional information to light transmission aggregometry. Well, if you find deficiencies with those tests, but also if you don't find these deficiencies, you can also consider to do more in-depth tests. For example, you can do DNA sequencing to check if there are defects in platelet proteins, and you can really look specific to inherited defects. Another very specific technique is electron microscopy, and you can use that to look for granule defects. Well, in general, if you use platelet function tests for bleeding disorders, of course, you pick up thrombocytopenia, but the platelet function disorders you pick up are mainly well-established platelet function defects, and they are also mostly quite rare. So, for example, using aggregometry, you can very effectively pick up Lanzmann thrombasthenia, which is the GP2B3A deficiency, Werner-Strié syndrome, which is a defect in GP1B or GP9, GI receptor disorders, collagen receptor disorders, secretion disorders, and storage pool disease. So this is a well-established technique in which you can pick up very effectively established platelet function defects. Well, another application for platelet function tests, which is very commonly used, especially in the last 2 decades, is the monitoring of the efficacy of platelet inhibitors. So when do we give platelet inhibitors? Well, mainly we give that to patients who had a myocardial infarction and had an ischemic stroke and are treated with a stent implantation. So what is a myocardial infarction? Well, myocardial infarction is a thrombotic occlusion of your coronary artery. And that coronary artery is blocked due to a rupture of an atherosclerotic plaque, which induces a very strong platelet activation. The platelet thrombus will occlude the coronary artery, and the muscular tissue of the heart will not be supplied with blood anymore. And if it's not very quickly treated, then the cardiac muscle will die of ischemia. So in this case, it's very important that you have a very quick treatment of these patients. And in the Western societies, the most effective quick treatment is in the hospital, in which you give the patient a percutaneous transluminal coronary angioplasty, which is also called PTCA. What you do there is you insert a catheter in the inguinal channel, and through the aorta you go into the heart arteries, and you follow the right arteries to come directly at the spot of the coronary artery which is occluded. The catheter has a balloon, so you can, if you are on the right spot, you can blow up a balloon, and the balloon places a stent, and its stent keeps the artery open. Well, a disadvantage of such a stent is that it's very prothrombotic. So these patients should always be treated at least half a year after the implantation of the stent with platelet inhibitors. And large clinical trials have shown that the most effective treatment is dual antiplatelet therapy. And in general, that's an inhibitor of the ADP activation pathway, secondary activation by blocking the P2Y12 receptor. And the other inhibiting mechanism is via COX-1 inhibitors. And the most well-known COX-1 inhibitor is an aspirin. And this dual antiplatelet therapy will prevent, if adequately dosed, a secondary thrombosis event. The problem, however, is that if your dose is too high, then you can also induce a bleeding risk. So it's always important to find a balance between preventing thrombosis and avoiding bleeding complications. And the bleeding complications are exactly the same as platelet function defects, as described previously. But the problem is finding the balance is different in each patient. So, there is no standard dose for dual antiplatelet therapy, but you need to measure in each patient which dose should we give, and then measure the platelet function. Well, this seems easy, but turns out to be more complicated than it seems, because there are many platelet function tests which claim to be able to monitor the dual antiplatelet therapy. For example, the PFA 100, the ROTEM and TEG, they are very commonly used for dual antiplatelet therapy because those machines are available in the hospitals for monitoring general bleeding disorders. And they also have an application for monitoring P2Y12 inhibitors, but validation studies show that those measurements are not very reliable. Well, another very commonly used method to monitor dual antiplatelet therapy is the Verify Now. The Verify Now is very popular because you don't really need well-trained technicians, so it's accessible in the clinic and can be used by medical doctors without extensive training, and therefore it's very popular. But also for the Verify Now, if you validate the test, then it is not a very reliable test to monitor dual antiplatelet therapy. Well, the other tests like flow cytometry, multiplate and aggregometry, they all have applications for monitoring the dual antiplatelet therapy. For flow cytometry, the best way to monitor, for example, P2Y12 inhibitors is the FASP test, which is extremely reliable. And but the disadvantage of all those tests is that it requires skilled technicians, and this is especially a problem in treatment centers which don't have a specialized lab. So although it seems simple, monitoring dual antiplatelet therapy turns out to be complicated in practice. Okay, then now I like to go to the main topic of this presentation is predicting thrombosis risk with platelet function tests. Well, first to start this subject, it's always important to consider, are platelets involved in thrombosis? And I think that we can answer this with a very clear yes, because there are several clinical trials, large scale. The clinical trials are randomized. That means that the groups are equal, and they have shown that dual antiplatelet therapy is more effective than single platelet therapy. And earlier trials have shown that single platelet inhibition therapy is more effective to protect against thrombosis than placebo. So we can say a clear yes, platelets are involved in the thrombosis, in the arterial thrombosis risk. But one complicating issue is that there are also many large cohort studies and many large case control studies who were not really able to show that platelet function tests are associated with thrombosis risk. So on one hand, there's causal evidence that platelets are involved, but on the other hand, platelet function tests, they lack the efficacy to predict a thrombosis risk. So that's summarized in this table. We have several platelet function tests. So PFA 100, TEG, ROTEM, they are global tests, but the platelet function tests are not designed to study the relation between platelet function and thrombosis, because PFA 100 and TEG and ROTEM are designed to predict the global bleeding risk. And they also have application for platelet inhibitors, but they really fail to predict the thrombosis risk. LTA, flow cytometry, and multiplate, they are very well optimized to define bleeding pathway defects. You can use them very well to monitor the efficacy of platelet inhibitors, but there's no application to predict thrombosis risk. Verify Now, FAST, they are designed to monitor platelet inhibitors, but are not suitable to predict thrombosis risk. So in other words, if we want to study platelet function and thrombosis risk, we have to think different. Now, one way of thinking different is just looking at the incidence of thrombosis in diseases which have a high risk of thrombosis. So there are many diseases in which thrombosis is a serious complication. Well, one remarkable finding is that most diseases which have the complication thrombocytopenia, they also have the high risk of thrombosis. And this combination is at least conflicting. So this seems to be a paradox, because thrombocytopenia means low platelet count, and everybody would say low platelet counts is associated with an increased bleeding risk. Well, in this table you see a long list of diseases, and in these diseases a common complication is thrombocytopenia, and another common complication is incidence of thrombosis. So, for example, hematological cancers, but also pancreatic cancers. It is known that the secondary cause of mortality is thrombosis. And another complication which is very common, is thrombocytopenia. Liver failure, the same, thrombocytopenia and thrombosis. Sepsis, exactly the same. So we can follow the whole list. And you will, so most recently, vaccine-induced thrombocytopenia. It's a combination between thrombocytopenia and thrombosis. Well, at the moment, we don't know the explanation for this paradoxical relationship, but we can form hypotheses for this. Well, first, most likely hypothesis for a relationship between thrombocytopenia and thrombosis is just that due to the underlying disease, you get an acute trigger for platelet activation, you form microaggregates, the microaggregates consume platelets, so consumption of platelet means thrombocytopenia, and microaggregates will lead to thrombosis. So that is a very straightforward and logical explanation. And in many diseases, this is also the most likely explanation. For example, in TTP, HUS, APS, SLE, ECMO, 2B for Willebrand disease, COVID thrombosis, heparin-induced thrombocytopenia, and thrombosis, vaccine-induced thrombocytopenia and thrombosis, you expect that platelet aggregation of agglutination is triggered. Well, this means that you have platelet consumption and you have microthrombi formation, occlusion of the arterioles of vital organs, and you have the combination thrombocytopenia and thrombosis. Well, for those diseases, this is really the most likely explanation. But there are also many diseases in which the thrombocytopenia is a lot more chronic, the development. And also the thrombosis is unpredictable and in a later stage. So then it's not likely that the thrombocytopenia is a consequence of microaggregates, and it's also not likely that the thrombosis is an acute trigger. Examples of those diseases are leukemia or pancreatic cancer, but also infectious diseases like dengue, inflammatory diseases like sepsis, specific COVID-19 thrombotic events, liver failure, chemotherapy. In these diseases, you have a much slower chronic process of platelets reduction. And we think what happens here is that you have in those diseases a continuous trigger of platelet activation, a continuous desensitization of the platelets. The platelets release their granules, they recover again, are triggered again by the pathogens of the disease, they release their triggers again, they recover again, are activated again, and at a certain moment they are exhausted. And exhausted platelets will become apoptotic. They expose negatively charged phospholipids on their surface. And this means an eat me signal and a procoagulant signal. Well, eat me signal means removal of the platelets. The procoagulant signal means a higher thrombosis risk. So you have the combination thrombocytopenia and thrombosis. Well, to be able to test this hypothesis, we really need a test in which we can simply measure the exhaustion of platelets. So that is something we designed. The principle of the test is very simple. We create a master mix in which you have a very high dose of activator of platelets. This activator, the same mix contains a reaction mixture to detect granule release. If you have granule release, you get light. And the more light you have, the more vital the platelets are, because the granules are more filled with granule content. So this is a method that the light intensity corresponds with the vitality of the platelets. Well, we tested this in a case control study with patients of multiple myeloma. And in this study, it was 21 patients, and we selected a control group which was as much as possible comparable with those patients, because it was 21 controls of the same age, the same gender distribution, and the same social economic state. For the rest, the patient and control pairs were invited exactly at the same time. So this guarantees that the treatment of the blood was completely identical. And so there can be no variation by the preconditioning of the blood. Well, first of all, we measured we compared the platelet count and platelet granule release in the controls. And what you can clearly see here is that the controls are quite closely distributed. We defined the cutoff point for platelet exhaustion by if you are above the mean minus 1.96 times the standard error of the mean, then you have normal platelet vitality, so no platelet exhaustion. If you fall below this horizontal line, then you are defined as exhausted platelets. The vertical dotted line is the line for the platelet counts. If you are below 100, then you are defined as thrombocytopenia, and if you are higher than 100, then you are defined as normal platelet count. Well, as you can see, the controls, they have normal platelet count and normal platelet vitality. If you now see the measurements of the patients with multiple myeloma, then you see that a minority of the patients, they have thrombocytopenia. So platelet count is below 100. And what you also see that there's a larger group of patients who really have exhausted platelets. So the granules are almost empty, and it means that they are really exhausted. And there's a small group which has both, so both thrombocytopenia and exhaustion. So this indicates that patients with multiple myeloma, they really have a continuous trigger of platelets. But we cannot draw conclusions about the impact of those measurements. So what is very important is that we need to do follow-up studies on these patients to see if those patients really have a higher risk of thrombosis. So that is one of the ongoing projects at the moment, is that we will study the incidence of thrombosis in multiple myeloma patients using those tests at baseline. Well, the third explanation for the paradox between thrombocytopenia and thrombosis is very simple. In diseases like leukemia, dengue, sepsis, COVID, liver failure, chemotherapy, we know that the blood is very active. The white blood cells are increased. There are several acute phase proteins, and most probably your platelets are irritated by all those pathogenic factors. Well, lucky for us, platelets are protected against complete activation, but the irritation, of course, takes place. Well, this means that in those patients, that only a minor trigger may be enough to activate the platelets. So it is a very likely hypothesis that patients with those diseases have highly irritable platelets, so hyperreactive platelets. And it's here drawn as platelets with a very short fuse. Well, we can measure this with a slightly modified approach of which I described previously. We have the same reaction mix. The only thing is that the agonist is optimized to a lower concentration, so we can pick up the sensitivity to this trigger of the platelets. So we have a suboptimal concentration agonist. The reaction mix is ready to use, so you can take it off the freezer. The only thing you need to do is 1 drop of whole blood, mix it, and you measure the granule release in time by measuring the light intensity. Well, in the graph on the right, you see in the blue that the curve is already coming up after a few seconds. And that means that the platelets react quicker on the trigger than normal platelets, like the red and the black one. And we can determine the irritability of the platelets by the lag time, so the time that it takes for platelets to start activating. Well, we did that in a cohort study of COVID-19 patients in Indonesia. What we did, in each patient, we measured on a fixed time point the irritability of platelets. So, and we measured that with the lag time by this trigger. And we followed them on mortality. And what you could clearly see was that patients with highly irritable platelets, that they had that was a lot higher in the decrease in the group that died than in the group that survived. So here we see a clear correlation between irritable platelets and mortality in COVID. Well, these are two examples. Of course, the idea is very new, and we are just in the start of the validation. But when you're just in the start, you need to be aware that platelets are, of course, never the only explanation for thrombosis. So although we find strong relationship, we should always keep our eyes open for other processes, because we all know that the vascular biology is also very important. We know that other blood cells, like red blood cells and white blood cells, they might also play a role in the incidence of thrombosis. And of course, coagulation. Thrombin generation is, of course, also very important in the risk of thrombosis determination. So in addition to studying single platelet exhaustion, we should also be aware that we should look at the whole picture of coagulation. So in each study we propose, we will also study the interplay between blood cells and coagulation, but that is not the scope of this presentation. That's the presentation of Joke Konings later today. If we want to study the role of platelets in thrombosis, then we should follow other strategies than the routine platelet function test. The routine platelet function test, they are very well designed for bleeding disorders. They are successful in monitoring platelet inhibitors, but they are not successful in determining thrombosis risk. So we have to think different. So in conclusion, we are now working on cohort studies in which we define a high-risk population. So, for example, leukemia or pancreatic cancer or dengue or sepsis, COVID-19, liver failure, chemotherapy. Those are all situations in which patients have a high thrombosis risk. In those patients, we will determine the exhaustion of platelets. We will determine the irritability of the platelets, and we will get the whole picture of whole blood coagulation, and we will follow those patients on the risk of thrombosis. And I hope in the next 2 years, so the next Thrombin conference, I can share those follow-up data with you. I thank you for your attention.